Yeah, we never, we
We're
never, we
game.
never, we never really have a plan, so that's fine. That's the best.
No, we don't.
That's how I work best is when I have no plan and just sort of wing it. All right, wonderful. So tell us again, who are you, Melody?
Melody Bishop RT, just your friendly neighborhood RT that tries to demystify the crap out of complicated shit.
Perfect. Nick, the floating vent guy. We have our new decal. I have to fix it. I will work on that this week. So we're going to talk about waveform asynchrony or dyssynchrony. You talked about that last week, which was interesting. Can you just remind everyone, i.e., remind me, because I always because people interchange them, but they're really not interchange. They're not interchangeable technically, right? Like there is a specific definition for asynchrony and dyssynchrony.
Yeah, and I'll be honest, I didn't actually even know it when I first learned. I learned it as asynchrony, but then through the course of my learning, I corrected myself with more knowledge. So the term asynchrony means full absence. So there is no synchronization. No breaths are matching. It is the vent's doing its thing and the patient's doing its thing. So that is asynchrony versus dyssynchrony would be anything that is not matched. So technically dyssynchrony can include just slight variations of a breath that isn't fully in sync versus a complete discord that is completely mismatched between the vent and the patient.
Got it. So even though we use it kind of interchangeably, it's technically not interchangeable. And I don't know how much that like matters at the bedside per se,
Yeah.
but it is like it is important to think that. So I think the point of this is that we're gonna look at these waveforms and then talk about how we should be fitting the ventilator to the patient if we can, and not reverse, like trying to fit the patient to the vent. Now, there are specific situations that we need to fix. We have to, affix the patient to the vent, i.e., if it's like a low tidal volume strategy, or if there's like incredible obstruction and you have to drop the rate to like 4 or 5 or something crazy, and the patient obviously not going to like that. But
Mhm.
and we have to do certain things to like allow the patient to sort of be in the passenger seat a bit while we sort of drive, while the patient goes through their acute illness. But outside of those situations, we should really be trying to sort of make the ventilator fit the patient, what the patient wants or needs. So that's kind of going to be the goal of this, I think. And we have some interesting waveforms. So I think you could see the first one, right? Okay. So Melody, some of these are mine in air quotes, meaning that I've co-opted them from other places. Some of them are actually mine, meaning I took pictures, and some of them are yours. This one I co-opted from someone, so I don't know the specific situation. So, that's kind of even not even the point, I think, right? Like we don't need to know. Like you can almost maybe think about the specific situation, what's happening just off of the waveform. I think that's kind of the next step for a lot of people is being able to identify what could be happening based off of the waveform analysis.
Yeah.
So what do you see here? What do you think about it?
Yeah, I think like one really cool thing about this waveform specifically is that you don't have settings or mode, but I think that that in itself is a really
Nice.
good it's a really good
Nice.
application for people that are learning waveforms because it's about, you don't have to know the settings to then be able to recognize.
Right.
Like when I look at this, it is really important to know what normal looks like, and you need to know the mode in order to know what normal looks like. But looking at the waveform, you can kind of find that. Like looking at this
Ridiculous.
to me, I think it's volume control.
Perfect.
And the
I
reason I
agree.
think that is because of the flow time waveform. It is a true descending ramp.
Yep.
Um, but then with that, then my eye directly goes to what I expect the pressure waveform to look like, which you can tell you do not have in this, which so right here, this is screaming to me that there is something wrong.
Would you agree with what I'm drawing sort of in this red that maybe should look something like that? Something more like that.
But yeah, and I would say with the descending, you probably would have a little bit more of a slope up to a peak later. But yeah, I agree. Like you would have
I love
more
it.
of a tombstone, but I would have like an asymmetrical tombstone. Yeah,
Like that? Okay, wonderful. Melody's a stickler for the rules, which I love. So we
you
are
taught me that.
yeah, so I know. Well, I'm drawing with a mouse. So it's like drawing. It's like trying to draw with my left hand because I can't do this on my iPad or else I would because then like I lose the camera and I don't know. I'm not smart enough to like have a whole setup. Plus, like this is like I'm a very junior podcasting situation here. So I agree. It should look more like a tombstone. So we're like kind of way off. And honestly, someone told me once if the pressure and the flow waveform in volume control look the same, like you're in trouble. Like there's something really happening that's the patient doesn't like. So what do you like? From a let's say from like the way I look at it, at least, is from like sort of a torture death perspective. So, if you ask me, do I think this patient is at high risk for being tortured or dying? I would say probably torture.
Yeah.
Would you agree with that?
100%.
Okay.
Like my next thing is once I kind of decide on what mode I'm in is then I think about which parts of the waveforms I can really look at to then see where problems are going to be. So with a true volume control, your inspiratory flow is going to be decided by what you set. So I won't necessarily look at my inspiratory flow waveform, but I'm going to look at my expiratory flow waveform to give me clues about the patient because that will always be patient driven. And then I'm
Right.
also going to look at my pressure waveform. That would be
Perfect.
my next kind of steps.
All right. So then would you agree that the expiratory flow curve is abnormal?
Absolutely.
Normally, we should sort of have this peak expiratory flow based on the characteristics of the lung, then sort of this, natural decay return to baseline, right? So I'm going to try to draw this, so just bear with me,
That's
right?
pretty
So
damn good.
pretty good, right? So then it should be this sort of purple. And we don't have that, not even by a long shot. So
Yes.
what do you think the patient's doing in expiration? Like, does that the yellow line at least, does that like make you think of a like any pattern or something?
Yeah,
You know what I mean?
they're working in expiration. They're
Okay.
actively pushing. And I think one thing to simplify this for people, because I know the flow waveform is confusing, what I like to teach people is anything moving higher on the positive x-axis is increased flow to patient versus anything going more negative is increased flow to vent. So I usually draw arrows going opposite directions. More flow to patient is positive, more flow to vent is the negative underneath. So then here you can see that we are getting extra flow going back to the ventilator in that
Hmm.
on the negative portion. And what would cause that? Extra muscles during expiration. What do you think? Do you agree with that?
I definitely agree with that. I think that, you know, so the I think that much like you, I try to think about what the normal is, and sometimes I'll even sort of take a picture and draw it on my phone, and then try to see like what I'm thinking. So certainly, you know, so what I have drawn in red, and like I'm gonna draw in, draw in green, which is probably not a great color to use, but I think we'll be able to figure it out. No, the green is all this pressure that's missing that should be
Mhm.
there, right? So in my mind, if it's pressure that's missing that should be there to be driving the volume, that means that someone else has to be providing the pressure, and that person is the
Yeah.
patient. So the patient is like breathing, as you mentioned, pretty hard, sort of throughout this breath. So if I at the bottom again, let's say like this dark red line, if we drew sort of the P mus, we would say the P mus sort of starts here, right? Goes all the way down, and then at the end of the breath stops, maybe not, right? Maybe the patient's just sort of working the whole time, right? Like maybe it drops, 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 and then maybe it lessens a little bit because you don't see like as much of a deflection upwards, whereas the patient's trying to pull up to trigger a breath. It's just that throughout this whole expiratory flow, it's not as deep as you would think. So as you mentioned, the patient's kind of working throughout this whole expiratory phase, like they're not in full expiration. As you know, I think you said this before at some point, and I say it too, expiration on the mechanical ventilator should be a passive phenomenon, right? We should just sort of
Yeah.
breathe out, and that energy, that work of expiratory breathing should be supplied by the stored energy that you load during inspiration and you load your the elastic tissue of the lung and the chest wall. But that's not what's happening here, right? The patient's like working the whole time. So I think
Yeah.
throughout inspiration and certainly expiration, the patient's like kind of pulling down the whole time, which number one, I can't imagine would be comfortable. And number two is certainly not safe, let's say for diaphragmatic purposes, right? Because on every single breath, the patient's doing the same thing. So the patient's working super hard to breathe on these, whatever these settings are, like whatever the flow is, or sorry, yeah, whatever the flow is, and also whatever the volume that whoever set the ventilator is. So what would you do? Like, what could you do to kind of ameliorate some of this stuff?
Well, I definitely think that they need more support. Like the way, just to kind of simplify what you said there, like the inspiratory side of the volume waveform, I would look at the pressure waveform, and the pressure is reading pressure of the whole system. So like that you said, the pressure that's missing, like that means that we pulled more negative. That has to be patient initiated. So they're pulling extra in inspiration, and then I think from what I see, they are applying expiratory muscles and pushing extra hard during expiration. This patient is working on inspiration and expiration. So they need more flow, more pressure, more support during the inspiratory phase. And I think if you offloaded that amount of pressure, that would definitely help overall with their work of breathing. So for this patient, most likely they are a little bit flow starved or support starved. So just to kind of get a sense of what they're doing, specifically what their inspiratory flow demand is, I would probably consider throwing them into pressure control. And then from there, looking at those flow rates that they are asking for, because remembering in pressure control, flow is variable mostly, and allowing patients can pull whatever they want. And then
Right,
from there, you'll probably see their inspiratory flow rate skyrocket as
right.
they are pulling all the flow that they want to then achieve that pressure that in pressure control is set.
I agree. I would probably switch them to pressure control or pressure support for that matter.
Yeah.
Now the issue becomes like this most likely isn't a switch it and then we're heading back to the call room situation, right? Because as much as this patient's working, they can certainly pull a big volume, which depending on the lung mechanics could be good or bad. Meaning, if they have sort of normal mechanics and they pull a big volume, you might be worried about volume trauma. I feel like there's probably a number for everyone where even in someone who you would allow a larger volume, let's say a patient with COPD, even a patient with COPD, you would allow a larger volume, but like, how big? Like a liter, it's probably like too much. You know what I'm saying? So I guess what I'm trying to say is that yes, I would switch him to a pressure-based mode, see what kind of volume he or she wants, and then see if that fits into our goals. So if you're like I sort of harp on the goals of ventilation oxygenation, you have your goals, which is like safe volume, safe pressure, safe expiratory time. Is that right? Did I say it right? Yeah. um, which essentially are the same. So for me, if I switch the patient to pressure control, and I do this all the time, honestly, because usually if you made me guess, I would say this is a patient with probably emphysema who gets put on volume control and gets tied to a volume that is, like 6 cc's or thereabouts, like 450 or something like that. And then they get super tachypnic. Um, there's probably auto peep mixed in. They get super tachypnic because they have this certain minimum ventilation demand that they have because they got a high dead space fraction. So if you switch them to pressure control, you allow them to take bigger breaths. They do it less frequently. That leads to, I feel like, better comfort. And I don't know if you remember this specifically, but we had this Instagram post about a month ago, maybe like the A versus B, whereas A was like, I think it was volume control. It sort of looked something like this. I switched the patient to pressure control because the patient was, agitated and all that kind of stuff. And when I switched them to pressure control, everything got better because they took bigger breaths, but it was less frequent. So for me, if you have a patient with emphysema, if they want a 700 ml total volume, but they're going to breathe 12 times a minute, I'd much prefer that than a 450 total volume and then breathing 30 times a minute, right? Because as you get faster, you're going to build auto peep and things are going to sort of get off the rails.
Yeah, I think what I would hope to see within a few breaths of the switch to pressure control is once you have fixed this flow starvation, the hope is that as the patient's work of breathing decreases and they feel more comfort, that then they start to slow down. With that, you're going to correct the auto peep that we are
Right.
having this waveform right now. And then with
Exactly.
that correction of auto peep, then they're going to have not feel as much work in order to initiate a breath, which then will also hopefully help them settle their breathing even further. And you may, and it might not work, you may have to then adjust some sedation, but you may notice that the
Right.
patient starts to settle so that they're not pulling these insane volumes because now they're at least satisfying what they wanted initially. So it's kind of one of these, you have to watch them closely, stay at the bedside, reassess, but just that switch and allowing them to have a bit more flow and more support might allow them to then settle enough that you can stay within your goals that you have it like kind of outlined so nicely.
Right. No, that's a good point. And I think, and the other thing is like, if you're in the situation where, again, the patient needs to be affixed to the ventilator, then your hands are kind of tied. Like you're going to have to increase sedation and or use paralytics if you decide that whatever the settings are, that these are important and the patient needs to follow them, if it's ARDS or if it's like obstructive disease, whatever it is. Um, because when you limit volume, and the patient's respiratory center is like on overdrive for whatever reason, whether it's acidosis or other things, um, you know, if you don't allow the patient to do that, they're going to do what they're going to do, and like this is what you're going to get, right? And then what you are doing here is like probably really causing diaphragmatic injury. You're certainly probably
Yes.
causing, uh, discomfort, like patient discomfort and all that kind of stuff. So
Maybe
you might
even
just
some P-silly as well, like with that massive pressure, like loss,
there's
like what's
yeah,
inside the chest. Like
100%.
you
No, I
can't do
mean
a plateau, but
for
I
sure you
wonder.
can't exactly you can't do a plateau, and you're certainly probably this peak airway pressure is probably like, I don't know, 23 at the most, right? 20, let's say 20, I don't know, whatever it is, 23, 24. Um, and we don't know why the patient's on the mechanical ventilator, but the amount of pressure they're draining because of how much work they're doing, their intrapleural pressure swing is probably like plus minus 15, right? Which is like a massive amount of intrapleural pressure swing for the lung to see, as you mentioned, the PCILI, sort of the patient self-induced lung injury, made famous by our late friend Gattinoni, may he rest in peace. But certainly is an issue, right? This is not safe mechanical ventilation, certainly. So something would need to be done. But
Mhm.
if at the very least you don't take anything away from this, if you're on volume control and your pressure and flow waveforms look the same, there is something wrong. So like figure out what's happening. All right. Anything else on this one, Melody?
No, the only other thing I would say is just reminding people in volume control, if you want to see what your patient is doing, remember to move to the waveform that is not set by you. So for volume control, you're going to
Right.
look at your inspiratory pressure waveform for patient effort. And then you can always look at your expiratory flow in every single mode, because that also is something that is from the patient. It should be from the patient because it's
Right.
not set by the vent.
Exactly. Perfect. All right, cool. Thanks, Melody. All right, Melody, who are you?
I am Melody Bishop RT, and hopefully trying to help you guys figure out the waveforms in a simple way. How about you, Nick?
Nick, floating event guy, floating everything these days. But we're going over some waveforms. Some of them are pictures, some of them are video. This one is a video. I believe this one is mine. I believe, meaning I took it. I believe. I'm trying to see if you can see me there. Maybe not. All right, so let's hit play. Holy Toledo, this thing is terrifying, huh, Melody?
It
So
is
just
awful.
as an aside, I I don't know if you saw, but one of these days, I can't remember when, I asked, can the peak airway pressure be lower than the plateau pressure in volume control? Yes, no, maybe so. And I think I've got sort of a smattering of answers. So this should prove to you that, and right now the peak is 5, right? So certainly the plateau pressure is definitely higher than 5. So your peak airway pressure in volume control can certainly be lower than the plateau if you have a patient that is like this active on the vent, right? So
Mhm.
that it's not always, it should be lower, right? Sort of by physics, but if the patient's very active, it might not be lower. So as you can see here, volume control, these are the settings I have at the bottom. I'll try to pause it so we can see. So we have a PEEP of 5, FiO2 of 40%, rate 15, volume 550, inspiratory time 0.9 seconds, a rise of 0.15, a flow trigger 1.6. That, like, I don't know why it's 1.6. It just gets like defaulted on the servos to 1.6. It's kind of weird. There's no T pause. Sometimes the peaks are high. 35 is little high for my taste. Breathing at a rate of 27 has a massive minute ventilation of 16, which is much higher than, which is like much higher than normal, right? And sort
Yes.
of, right, like just as a number is high. And what else? Anything else you look at, Melody, like as far as settings wise goes?
Well, hey, just a couple things also with the predicted body weight. We have it right there on the screen. That's
Yeah.
mils per kilo, a predicted body weight. You can tell that breath to breath, it's going way beyond what is considered safe. One
Right.
thing that I just want to draw everyone's attention to is looking at what is set. And Nick just mentioned the settings. Like these are what most of us in the vent world, especially people that are new to vent, seem as safe ventilator settings, normal ventilator settings. And yet we have very dynamic, complex waveforms that are showing us that the patient is tortured. And this is a key takeaway message that just because your settings are safe does not mean it is actually safe for your patient. Because this is where the waveforms start to come in and why it's so important to start to move through a basic understanding of what waveforms should look like.
Right. Because, I mean, this is a little bit of a, like, oh man, this is so bad. So if we go back to our initial kind of like, what should it look like? And I don't know, maybe I'm too pie in the sky that like everyone should understand what like a normal waveform is. I think we can all agree that even if you spend any time in the ICU, like this is completely off the chains abnormal, right? And the thing that is so impressive is that if I break this down into a breath, like let's say here, so the lines are not straight, Melody, don't yell at me. I'm using the mouse. I can't do it. If I had a pen, it'd be better, right? But if we say this is the inspiratory time, right? During inspiration, the patient is pulling down so hard that the peak airway pressure is not 5, right? It's like -4.
Mhm.
So they are pulling so much flow out of the, and maybe Melody, you can talk about this more because like this is probably more of like a like ventilator, like how it actually works type deal. And correct me if I'm wrong, but in volume control, like there's a certain amount of flow and pressure, like literally in the tubing, right? So the
Yeah,
patient pulls down so hard they can pull all that flow and subsequently all that pressure in the tubing out, and
yeah,
this is what you get. So like the tremendous amount of work this patient is doing is just, instead of it being like a peak area pressure of like 25, for a lot of this breath, it's like either 0 or -4. And it probably only goes up to this number here because the patient is like tired or just like lets go of that pull. And then it just sort of rebounds back to this number. And then we go into expiration and the cycle begins over again. Like even in these two, right? Right here. I mean, this is like -4. I mean, it's just, it's, it's unbelievable the amount of inspiratory pressure that the patient's generating to make the waveform look like that. It's just like crazy stuff.
yeah. You hit the nail on the head there. Like just to kind of get into the nitty gritty very, very quickly here. In volume control, we should have a set amount of flow in the circuit. You also have bias flow that moves through, but that means that there is a set amount of flow available. This patient is pulling and exhausting all that flow and probably opening the anti-suffocation valve that every ventilator has and literally pulling extra flow. Like
Yeah,
that
that,
is
and that's
that
and
is
that's
what's
why
happening.
that's why this is because it should be decelerating. Actually,
Yes.
I lied. No, wait, I don't know. Let me think here. Is this a square or a decel? Now it says a McKay, and it looks like the flow pattern is 100%. Which on McKay, when the flow pattern is 100%, I believe that's a continuous flow. So this might be continuous flow because on McKay is like there's this flow pattern percent. I'm pretty
Yeah.
sure 0 is a decel, and 100, which this is square. It's so stupid. I know, right? It's so confusing. So that's probably why. But either way, like even if this was square, it still doesn't look like that. Like it's not sort of as square as you would think because they probably are pulling more flow out of. So that's actually interesting. Can you say that again? So there's an anti-suffocation valve,
Yeah.
which if you suck down hard enough, you can open and get more flow. Is that right?
Yes, like there's just
Very interesting.
safeties that are put in place for whenever like the circuit completely is starved. You can also have that if you ever have a blocked exhalation port that the anti-suffocation valve also opens. And it's just like one of those fail safes that ventilators have in case of complete failure. But it also just can cause massive issues for you when you're trying to figure out what your patient's doing.
Right. Now this person's. Holy Toledo is like pulling down super duper hard, right? On VC. So I guess the question is like, how would you remedy this? If Dyssynchrony, like what kind of Dyssynchrony would you call this? Meaning, if we maybe we do this like right now. Let's say, so to me, major Dyssynchronies, right, are a triggered Dyssynchrony, right? A cycle, goal,
The third one I usually say is demand. That kind of
demand.
covers
Interesting.
the flow
Okay.
starvation. That's like I just kind of
So
classify that.
flow. Okay. Yep.
Yeah. But like you can have it technically in pressure control, which I don't like calling it flow starvation because flow is variable. So I usually like to say demand
True.
to keep it simple, but that's
Okay.
just my own term. That is
I
not
see.
technically
I see
technical
what you
one.
mean. I see what you mean. So what would you call this? Would you call this a trigger cycle demand?
Well, I see more than one issue, to be honest.
Touche.
Like I see all three of them.
Hmm.
Primarily, it looks like it's a demand.
Okay.
But at the end of the day, we have a bit of a triggering issue because we have auto peep. So the patient is trying to trigger, and I think we have a little bit of a delayed trigger. I think that if it is a square waveform, you could actually have a little bit of a cycling issue as well with
Yeah.
that decay and flow
Right.
that you're
I
seeing in
mean,
that waveform. So
you
it
mean
looks like all of them.
in the expiratory flow?
Yeah. Well, in the inspiratory, when it notches down, and then you see the increase in pressure. What do you think, Nick? Because like to me, if it's a square and all of a sudden our flow is notching down, it could be because the patient is actively exhaling,
Yeah.
decaying, and then and then you end up getting technically, if you I hate to say the word vector, but like if you have the patient pushing the opposite way, it's going to give the overall resultant of less.
Yeah.
If the
Meaning
vent is used.
like right here.
Yes.
Yeah. No, I think you're right. I think like while point 0.9 isn't that point 0.9 of a TI isn't that high, sort of like maybe on the higher end of like normal, but not like it's not like 1.5 seconds, right? Like it's still sort of within like I don't actually what what does RT school tell you normal TI? Do they give you a number or is it
Yeah. So for an adult patient, it's technically zero point 0.8 to 1.2.
okay? So
So it's a
yeah, so
normal eye
it's
time.
even yeah, it's even right exactly. So it's even so even by that it's like right in the middle.
Yeah.
I think because of how tachypnic the patient is, like
Yes.
pulling down super hard, then blowing out super hard, which is
Yes.
why you get this like I mean this like peak expiratory flow -60 is like pretty high. I mean,
Mhm.
like you don't normally see -60 in normal lungs. Certainly you could see it in like ARDS. I mean, I guess it's not like the highest ever, but like it's not, -40. I mean, -60 is like pretty high. So he's probably blown out at this point, which is why you see this uptick in the pressure, as you mentioned. And then just sort of like actively blowing out this whole time, and then sucks back in super hard, boom. And then we go through the inspiratory phase again. So sucking down super duper hard. So if I drew if we just said like the P must part of it for the inspiratory for inspiration, like and I'm going to put a straight line, but just because I'm just putting a straight line. But once we hit like kind of here is when the patient starts to suck down super hard and then pulls that circuit all the way down, all the way down, all the way down, and then lets go and then starts to breathe out super duper hard. Now it doesn't cause as much of sort of like this uptick here as you see in this one, but I agree. I think he's trying, one of the RTs in my fellowship would call it, he's trying to like switch the vent off, like he wants the vent to go into expiration early. So this is certainly like a cycling issue. I don't know if I see any trigger issues per se. He might get a trigger issue eventually if he's like so much auto peep that he has to overcome all that as well. But there's certainly like a super duper large mismatch in the flow and as you put it, the demand. Like so, the patient either wants the flow to be much higher, or what probably is more accurate, needs more support. Then the second question becomes, why does he have such a high MV? If this is from like metabolic acidosis, right, like renal failure or something like that, that could be the reason. It could be like a big VQ mismatch if like it could have a big PE, could have ARDS, pulmonary edema, where there's a lot of dead space, so you need a massive minute ventilation to sort of achieve a normal pH. But whatever it is, the vent at this point in time is not giving the patient enough support, certainly, to meet that demand. So do you so would you do the same thing, like sort of switch to a pressure mode, or like
Yeah. And
would you make the TI lower? Like would you make it point 0.8 or like point 0.7 or point 0.5 or something like that?
honestly, I think this one's kind of past that. I think right now you need to
Good
just
point.
allow, like the patient has so much active effort. You don't even have time to get sedation under control and try to settle. With this degree of auto peep, I would move right to trying to just let the patient do what they're trying to do. And I would probably just go to pressure support and then try to in tandem with giving them a bit more opioids and trying to settle them a little bit, trying to get them at least comfortable on pressure support for me to see what their intrinsic respiratory effort is. Because like again, I do see missed triggers and a delayed trigger in this. I see a deflection negative in the pressure at the same time we're having a positive in the expiratory. I think this patient, if you watch their chest, would be breathing rapidly at a rate of 40, in, out, and actively inspiring and expiring. So I think that what I would try to do is get them into pressure support, probably at a pressure support of 10, let them have that rapid breath and see if they will start to slow down
Hmm.
naturally with that support. And then once I get them slightly more comfortable, then I would probably move to getting them back into a control mode, starting with pressure control, and then maybe if I need going back to a volume once I get them settled. That would be kind of where I'll go to try to rapidly fix this as fast as I can.
Hmm. Interesting. Would you? So what if like some jabroni fellow or junior attending like myself comes along and says, Melody, I'm gonna paralyze the patient because like the vent's out of hand. He's, too tachypnic, he's agitated, da da da. Like um what possible issues could we run into if I did that?
Well, first off, the patient isn't adequately sedated to be able to be paralyzed yet at this point. And like when you're dealing with air hunger, like the research that I know is saying that they're still going to be experiencing that. Like we need to fix this. In
Right.
my strong opinion, I would advocate for them to give me 5 minutes with the patient to try to settle them. And like walk away, trust me, give me 5 minutes. And I will call you when we are ready for paralytics, if that is where we're going for, trying to protect the lung.
Yeah.
'Cause I need to address the catastrophic air hunger and dyspnea that this patient is having.
Right. So I don't know, and I almost want you to read my mind, but it's impossible, obviously. But my point is like, so that's number one, 100% true, and that's been brought up a bunch of times, certainly within the context of COVID, that people I think emerge from their comas with thoughts of like they're drowning and they're being suffocated, all that kind of stuff. So certainly connected to that. I guess my point is like, if you just walk by and saw that and reach for a drug, you don't know why the MV is so high. So once you hit that paralysis button, you're going to cut that MV probably into at least half. I don't know what's 15 times 550 is probably like 500. It's like 7.5 or 8. So yeah, probably about half, right? So if, you know, there's a there's a large range of things that could happen. If you're at a pH of 735 with a PCO2 of 4 of like 50, and you decide like, all right, I'm just going to paralyze the patient. It's just easier. I can go back to sleep. That PCO2 is going to rise tremendously, and then the patient's going to get super acidotic, and then you're going to be it's going to be a whole other issue that you're going to have to deal with. So, like these high minute ventilations really get me nervous because if I don't have a good reason for it, or even if I have a reason for it, I guess, like, let me take a step back. What I mean is, if like let's say this was the worst kind of person to put on the vent, like a patient with DKA, right? And they
But
have
I
a
was
tremendous,
thinking, this is
yeah, I
screaming
know, yeah,
DD to me.
exactly. And maybe it is. I don't remember when I took this, but if it was a DKA patient or just any person with severe metabolic acidosis who has a tremendous minute ventilation, it's like basically impossible to support them with the ventilator with a tremendous minute ventilation. It just like you just you kind of can't. Like it's never gonna look good. It's always gonna look not great because
You're going to break rules. You're going to 100%
yeah,
break
you're gonna break
rules.
rule exactly because you're asking the patient to take care of that minute ventilation need through something that is certainly narrower than their trachea. Right? And even if you have a big tube in an 8.5. The only time we put in 8.5 is in the Bronx suite when we're doing like EBUS. Like in the ICU, very rarely put in 8.5. But in patients who have like obstructive disease, certainly should have a bigger tube, maybe not 8.5 because then you have to trade off. You're going to get like subglottic stenosis and all that kind of stuff.
Yes.
But like even just an 8, let's say, it's still smaller than the trachea. So, if you're in that situation here, which is the patient has a tremendous minute ventilation need, um, the only thing you can do, as you say, is do the least amount of harm and try to support them the best that you can, because it's never going to look pretty. But certainly, this isn't even close to something that is passable, in my opinion, honestly. And
Mhm.
as you mentioned, if you give them a little bit of support, like fixed support, fixed meaning, and you know this, Melody, I'm sure, but just to, like textbooks and stuff. So if this is support and this is work, right? The support goes down as you work more. That's things like VC, our favorite PRVC, right? So the more you work, the more support goes down. And don't make fun of me because I can't use the mouse. The reverse of that is things like PAV and NAVA. And I guess, I don't know, like the Hamilton stuff is like one of the Hamilton modes. Like, I guess
ASV.
at ASV, right? Yeah, like
But
ASV.
actually, don't put it there because it is technically a PRVC based mode. So technically
Okay, so
speaking, it would do the reverse.
I'm gonna do this. I'm just gonna do PAV NAVA because that's sort of like the classic stuff.
Yeah.
But the one that's just the same, right, is just the normal pressure stuff. So pressure support and pressure control. So, instead of us trying to be sort of cutesy with things, when things are off the rails, I'm just like, all right, I'm going to give the patient a certain amount of support and then figure out from there, like
Yeah.
what I need to do. Do I need to increase the eye time? Do I need to increase the pressure support? Do I need to am I, this is what it is, and like I either have to accept that or take over as far as medications go. Because while if there's anybody that gets PRVC the hardest time, it's obviously me because it's the worst mode in the universe. But the problem is that because of the way it looks, like it just looks like a regular pressure control, right? And everyone, I
Yeah.
think, now correct me if I'm wrong, but I think if most people walk by and just look at it and they're like, oh, that looks normal, even though it could say 5 or something, right? But I think if most RTs walked by and saw this, like just this part of it, I think most RTs would be like, wow, that looks horrible. Like, what is happening there? Do you get that? You think that's fair, or am I off the rails
No,
here?
I think most nurses, no, I shouldn't say
Yeah,
most, I think all nurses would look
yeah.
at that and be like, let's page
So,
the RT stat.
yeah,
Like
something's wrong.
100%.
Exactly,
This something,
exactly.
and that would be alarming. It would be just
Right,
bad.
right. Although this, yeah, well, The alarm thing that's a whole separate issue, honestly.
Yeah,
But
it's true.
so this
How
is
wide were they set? How wide were they
they're
set?
right here. You can see it. So the MB of 40 and 5, respiratory
Yeah.
rate of right. So 30, which is drives me nuts. I mean 30, I don't know. I like what do you again, that's more like an RT thing. Like what like there's a trade-off, obviously, right? Because you can't make the respiratory rate like the alarms, 8 and 12 because then it'd be alarming all the time. But I feel like is there a better is there a better number than like 5 and 30? I don't know. Like that's like is
Yeah.
it I guess another question I always had is I'm so glad you're here. So in RT school, do they tell you, make the alarms X or Y for some reason, or do you just is that just kind of like up to you?
There, I think there's hospital procedures and policies as well, but in RT school, technically we're taught to put our alarms 20% above and below what normal is. But I
Interesting.
can tell you right now that that is not normal practice. Even myself, I tend to have wider alarms, but I am also a very present bedside
Yeah.
RT. Like I
Right.
don't round the minimum. I'm usually in the ICU every hour, if not more
Right.
frequent. So
Yes.
I think there's that trade-off of it depends on the clinician and the patient. On if you have a patient that is very light, sometimes you have to be a bit wider because then it's going to be
Right.
nuisance alarms and you can't have that. But
Right.
like textbook says 20% above and below.
Interesting. All right, good. So now I know. Now I can tell the RTs that they're not it should be 20% above and below. My friend
You're
will
gonna
not get
hate
that.
me.
No. Well, they're gonna be like, who told you that? I'm saying Canadian respiratory therapist. They won't even know who you are, so it'll be fine. All right, so this one is horrible. I got to be honest with you. I don't know what I did. I probably switched them to pressure control because that's my normal go-to to see what they need. And in the midst of all this, I probably am trying to sort of figure out how I can make this MV need better, or if it's something underlying like DKA or metabolic acidosis or something of that sort, trying to, make that better. Because back to the normal physiology, which is interesting. As you know, we breathe a response to CO2. And if there's like some process that's causing more acidosis, we're going to breathe harder and faster to breathe off that CO2, at least in the short term, as our kidneys sort of gear up. But if we have kidney injury, we can't do that because they're not working. So then that becomes a whole other issue. But anyway, so this is horrendous. This certainly should show you that the peak airway pressure, while should be higher than the plateau pressure in volume control, is not always true, especially if the patient's working tremendously on the ventilator.
Mhm.
And oh, I am there. Look, see, that's my head right there. See it? Yeah. Anyway, all right, great, wonderful. Thank you, Melody, for teaching me how to go through that. Wonderful. Thank you. All right.
One other comment about this though
Yeah,
is
yeah,
that
yeah.
the decision between pressure support and pressure control, I think, is semantics. But one reason why I would have moved to pressure support for this one specifically is because I did see cycling issues as well. Since pressure support, just reminding people that instead of a time being the cycling mechanism, it is a flow
Uh-oh.
cycling.
Uh-oh. Okay.
So
So what?
because of that, it should be easier for the patient to then trigger and come out and not have to match that time. But you could absolutely go pressure control and then try to watch and match their inspiratory time to cycle it.
So to be direct, Melody, what is the difference between pressure control and pressure support then? Because everyone always tells me that pressure support is just spontaneous and
No.
that's all. So what is that? What is the difference?
The only difference between pressure control and pressure support is that pressure support cycles with a flow decay versus pressure control cycles with a set time. But you can absolutely have pressure support act like pressure control if you do not know what you're doing.
Cycle is the set I time. PS cycle is the percentage, that's and
Yeah.
percentage of flow decay from peak inspiratory flow.
Yeah. So when you think about when you breathe in, if you everyone here takes a big breath all the way to the top, if you're thinking about the flow, you'll notice that your flow starts to slow down as you approach full. And that is a normal physiologic process in our lungs. So pressure support literally tries to be spontaneous by banking on that natural decay that happens in inspiratory flow. And you can think about a patient, if they stop breathing in and they start to try to breathe out, that will naturally also decay the flow. So it's a
Mhm.
computer trying to synchronize with a spontaneous breath by banking on normal physiology.
Now, Melody, let me ask you a second question. If I have a patient with emphysema who's on pressure support and I set that cycle decay to 10%, what could I possibly cause?
um, you'll end up having cycling dyssynchronies. Like absolutely you will. And
You'll
they
have
could
cycling,
present in
right?
multiple different ways. Like I'm definitely going to be hitting on this a lot because I think pressure support is so poorly misunderstood. So
Hmm.
like you have to, when you think about pressure support, you also need to ensure that cycling of pressure support is matching your patient. So if you have a patient who is breathing faster, shorter inspirations, they need a higher percent decay. So that means the breath is terminating quicker versus potentially a long and slow inspiratory phase. You can think of a patient that's like narcotized, has too much opioids on board. You can think of those patients that you're giving Narcan to. How do they breathe in? Nice, long, big, slow breaths. You can also see this in neuro patients. They might
Hmm.
need a lower percent decay. So the
Hmm.
inspiration is going to be longer to decay down to that lowered percent.
Right. And the other, so what we teach the fellows and attendings, I mean, not that I would ever teach an attending because all the attendings I work with are geniuses and know better than I do because they've been practicing for so long and I'm just some schmo. But the problem in emphysema is if you set the cycle decay too low, remember, since the lung is so compliant, meaning it takes a very small pressure differential to generate flow, you can theoretically trap the patient in inspiration forever because they will never be able to decay that flow to that number of 10% or something, right? Because if their peak inspiratory flow is 100, they need to get to 10. But in a patient with emphysema, if you just have a tiny bit of pressure differential, you're going to generate a flow because the compliance is so good. Good in this situation means not good, right? And as you mentioned, you're going to lead to a cycling dysynchrony because the patient is going to try to be pushing out and they're not going to be able to flip the ventilator. So there are some small studies to suggest that patients with COPD do better with cycling percentages closer to 50%. Normally, and I put normal in air quotes because I don't know how it is with you or like the Hamilton stuff, but if you pop the servo over to pressure support, the cycle percentage is usually at 30%. And then if I look at it and I see that they're trying to cycle the vent and it's like the percent's too high, I'll go up on it. Like I'll go from 30 to 50 or whatever it is. You know, if they want to breathe faster or if they want, if certainly if it's a patient with COPD or emphysema, I'll just go right to 50%. So it's important, like, and it's a little confusing, right? Because if your cycle percentage is high, that means that it's going to cycle faster and you're going to be able to go from inspiration to expiration faster. If the cycle percentage is lower, you're going to go from inspiration to expiration slower because you're going to have to get to a lower flow, right? If you go from, if it's 30% and your peak inspiratory flow is 100, you're going to have to get to 30 liters until the ventilator is like, oh, Melody must want to go into expiration. Let me cycle off into expiration. So, which is brings up the next point, which I guess we might as well, what the hell, we might as well do it. But um, SIMV, right? SIMV, let's say SIMV PC, like what is really the difference, right? Like what, like there is no difference, right? Because the spontaneous breaths are handled as pressure support. The control breaths are pressure control. As you mentioned, the only real difference is the cycling mechanism, right? So when someone tries to say, "Oh, we're on SIMV because we're weaning or something," like that doesn't like it doesn't really make a ton of sense to me. You know what I'm saying? Because it's just like the cycle thing. It's just the cycling mechanism that's different.
Yeah,
Would you?
and then the problem that I have is that
Hmm.
like at its fundamental core with SIMV or SIMV as you call it, is that like because you are now having two different breaths with two different cycling mechanisms, trying to match those two is very, very difficult. So then you are
Yes.
literally varying the level and support breath to breath. And the brain cannot predict what level support it's going to get. So then it's going to
Yes.
predict based on the last breath. So then it's like, I didn't get a long enough inspiratory time in that pressure support breath. The next
Hmm.
breath, I'm going to work harder. So then it works harder. So then you, at a clinician at the bedside, are going to be seeing varying dysynchronies that are presenting themselves in very strange ways because the patient is actively chasing a moving target and you are now actively chasing a moving target. So then you try to adjust your flow sensitivity and your pressure support breaths. But then that's going to change the support that the patient gets. And then they're going to change their work again, maybe in the control breaths. So then you
Right.
change your inspiratory time. And then you like it's just this vicious cycle that you have just put yourself in.
Right. And I will show the paper and or link it that there is there there is evidence to suggest that that is true. And I think it's, I don't know how many patient series it was. Maybe it was small, but they dropped esophageal probes and they calculated the pressure time product. So basically, like they look at the esophageal pressure during inspiration. And then if you integrate the time, then that talks about how much work the patient's doing. So patients actually did more work on SIMV than other modes because of what you're saying exactly, which is that the brain can't anticipate the loading pattern. So it's one loading pattern with pressure control, it's another loading pattern with pressure support. So it sort of is cheating on to work harder. It's sort of like if I filled up a suitcase and told you there was a bunch of bricks in it, and I said,
Yes.
Melody, there's a bunch of bricks in the suitcase. It's gonna be super heavy, dude. Like you gotta really, like take your pre-workout, eat your greens, and then make sure you stretch because it's gonna be super duper heavy. You're gonna have to lift it. And you're like, all right, bet, dude, I got it. I got this. I got this. And then you're getting hyped up. And then you are like, all right, one, two, three. And then on three, you give a big old heave ho. And I said, gotcha, it's empty. That suitcase is going to go flying because your mind was set on it being super heavy. So that loading pattern
Yes.
that you're sort of recruiting all of your muscles to lift something you thought was going to be super heavy was not true, right? So now the suitcase is going to go flying. Same thing with the diaphragm. So the brain is thinking like, all right, there's these loading patterns that are different. So am I going to have more or less support here? So it's going to work harder. So there's like evidence to suggest that SIMV, like the funny thing is it was propped up as like to wean patients from the vent as like a working thingamabobber, but in fact it just made the patient work harder and probably led to more ventilator days, which
Oh, it did. Like
we know,
the
yeah,
studies for
we
that
yeah,
100% are proven for sure. Yeah.
right. That study from 1999, I've linked it recently. I forget the guy's Esteban, maybe. I think it was Esteban. Anyway, so we know that. So SIMV is terrible. Don't use it. if you think you're trying to be slick, you're not. You're being dumb. We're going to call you stupid and talk about you on Instagram Reels. So, well, that was an interesting segue into SIMV. All right, wonderful. All right,
Yeah, that was totally by
I can
accident.
I can probably.
All right.
All right, Melody, who are you?
I'm Melanie Bishparty, just here to explain some of the squiggly lines on the vent and try to make it as simple as possible.
Yes. What are the
How are
squiggly
you, Nick?
lines with the floating vent guy, Nick? Yes. What are the squiggly lines? So, this is the much what do you call it? I'm not going to say maligned. It's like much beloved T1. I find it not. I find that I don't think is it amazing? I don't know. I guess it's kind of small for my taste, to be honest with you. Like the screen is tiny. I would need to really have my glasses on to see it, but I don't use the T1 much. Not much ever. I never use the T1 because we have McKay's. So Melody, so PCV plus, like what is that exactly? Is that like a presumably is a pressure mode, obviously, but so is that targeting a volume? Like how does that work exactly?
No, this is a full pressure control mode. This is pressure control. I honestly, the Hamilton T1 has added pluses for like CMV plus to refer to the fact that it's PRVC. And I honestly think that in the branding, they just didn't want to put pressure control without a plus, and they probably just wanted to look equally cool, so they just added a plus. So
So
all
it's
of their
just
modes have
so
pluses.
it's just pressure control. It's just like normal pressure control.
Perfectly
All right,
pressure
got it.
control.
Okay,
Yes.
got it. All right. So since this is a U, um, man, this is really interesting. So since this is
Yeah,
a
I get to
U,
ask you. This is my turn to ask you, Nick.
yeah.
So
So this
this
this is
is
a U thing. So let me see here. All right. Yeah. What are you asking? Let's see here.
Okay, Nick. So again, you can't see all the settings, but
Yeah.
the inspiratory time on this patient was zero point 0.9. So a normal inspiratory time for an adult patient.
Yep.
And this waveform screen was sent to me for some advice because it was a bit of a difficult to ventilate patient.
Okay.
And what are your thoughts?
So my initial thoughts are so number one, you know, so let's try to break this down into sort of breath by breath. So let's go here, and it's not straight. I don't want to hear it. I'm using a mouse. I can't use my I can't use my
For everybody watching this, just so you
I
know,
can't.
this is the dude that gives me grief when I send him
No, this
drawings
is
of
what
my
this
waveforms.
is what a mouse does. This is much harder. This is pretty impressive. I'm doing this with a mouse. So a couple things.
I
One
am
is that,
impressed.
you know, pressure control, you shouldn't really have a linear rise in the volume, right? It should be sort of this exponential rise because theoretically, when when you start the breath, your pressure control, so you should go from your PEEP up to your set pressure, which should then stay there for a certain amount of time, i.e. your TI, what you set, which is zero point 0.9 here, then it should drop during expiration back to PEEP, right? And that's not what you sort of have here, right? You don't really have this like nice upstroke in pressure. And I don't know if that has to do with like the rise time of the pressure. It's not here, but like maybe that has something to do with it. It's like sort of a I'm to be honest with you, I don't even know what would do that because the only thing that gives you a linear rise is volume control of the square waveform. So I don't, that sort of jumps out to me, number one. Number two is that um, on the flow, it's sort of like, I can't see it here. So I guess it's higher than even the screen can see. So it probably goes up to here. But, it's sort of this straight line down too, right? And you really wouldn't expect that. What you would expect is sort of up to here. If it's a spontaneously breathing patient, or sorry, if it was a passive patient, you'd expect this natural decay down to the baseline and then cycle off into expiration, right? So the flow pattern is sort of all kinds of wonky just out of the gate. So weird pressure, weird flow. I think if we get into the sort of Dyssynchrony talk, there's probably a little bit of a delayed trigger because it kind of looks like, to me at least, it kind of looks like that the pressure starts to dip back here, right?
Mhm.
It's now you're getting a trigger, right? But it seems to me that the pressure starts to dip here. So you have this like very tiny delay, which would correlate to the flow kind of starting to go up. So the patient's starting to pull on the vent to try to get the cycle into inspiration. So what are causes of delayed trigger? Number one could be the triggering mechanism is too high. So, like if it's a pressure trigger, you set it too high. Like they need to do a pressure trigger of like -4 or something, right? Which would mean that it's harder to trigger the ventilator. The other thing that's more nefarious is auto peep. So then the question becomes, are there signs of auto peep here? And if you've been following along with my sort of craziness, you know that that's kind of like a main thing, a mainstay in our discussions is there auto peep? And I don't know if there's, I think is the area under the curve different? I don't know if it's different. It looks almost similar. Maybe you can talk me into it's a little bit different, right? The area under this curve and the area under this curve is sort of about the same, maybe a little bit less. It certainly doesn't get to the baseline there. This is interesting too. So, this peak expiratory flow, and then instead of this nice exponential decay to baseline, you don't have that. What you have is like, it almost looks like there's a differing time constant from the peak expiratory flow to when the flow starts to exit the lung, right? It kind of like hits this, boom, and then it just stays straight. So is the patient trying to sort of breathe out? So does that mean that there's some obstruction that's causing that pattern? I think there could be. Um, if we look at the volume curve, you have a little bit of you would call that a leak, right? But that leak is a little bit misleading. It just means that the ventilator isn't seeing all the volume that it put in, right? So the question is, where is it going? Is it going around the cuff? Is it going through a chest tube that you put in because there's pneumothorax? Or is there auto peep, meaning there's flow left over and subsequently volume left over, and then subsequently after that, pressure being exerted? The other thing is that your exhaled volume is only 187. I don't know if this is like, is this a adult or a child?
It
Would you
was an
guys,
adult.
as an adult, right? So this is kind of low, right? Um, and these, and you're getting differing amounts of volume per breath. So what that can mean is that, is the patient breathing differently in each breath? Is there auto peep that is then sacrificing the compliance, making the compliance low? And when you have low compliance, so when you have auto peep on pressure control, the way that you die is from hypercapnia because your total peep goes up. So if your inspiratory pressure, which here I believe is the delta pressure control, which is 5, right? So your peep is 7, your delta P is 5, your peak area pressure is 13. You know, the peep is probably not 7 because you're not accounting for the auto peep. So if there is auto peep, instead of a delta of 5, the delta is probably, if there's auto peep and it's 10, now your delta P is only 3, which is why your inhaled volume is low, which is probably why your minute ventilation is 3.4. So I think in the totality of it, so a few things. One is that I'm not exactly sure what's going on here in these. Sort of interesting, because it kind of looks like, the pressure goes up, right? This flow pattern is certainly weird because it should go up, but it doesn't. And it doesn't sort of go up till here, till you're sort of into the breath. And then the pressure is pulled down. So does that mean, in the first half of the breath, let's say, you're not getting any flow because there is no delta being generated because there's auto peep? Then in the middle of the breath, the patient sort of turns on and then they start using their muscles of inspiration so forcefully that they're pulling flow. So now you actually have a flow. If you ask me, like, what does that sort of resemble? This could resemble like a reverse trigger because
Yeah.
the initial part of the breath is machine trigger. So just to explain, like, what's a reverse trigger? So, reverse trigger, so we talk about cycling asynchronies. Um, a double trigger, by definition, is when the machine inspiratory time is shorter than the patient's neural inspiratory time. So the patient wants a longer inspiration. So what that looks like is if you go into expiration, right? Sort of this deflection up because the patient's trying to breathe in, right? Now there's varying degrees. Like this is mild, this is moderate. The most severe would be if the patient then triggers the ventilator again. We call that a double trigger, right, Melody? But the first breath is patient triggered. Reverse trigger is when you have this pattern, but the first breath is machine triggered. Then what happens is the diaphragm gets loaded and then it sort of invokes this reflex called the Herning-Brunner reflex. Herning-Brunner, I can't say it, but you can look it up, Herning-Brunner. Then the diaphragm contracts, which is what you're having here, right? Sort of this violent contraction, because it's contracting pretty hard because it's pulling pressure out of the circuit. So I would say that it's like, it's like a forceful contraction. And then you have the flow, you have a pressure differential, so then you have flow. Then you have a volume. Now, you know, that could be leading to auto peep, which is then leading to low tidal volumes. I would need to ask Melody, what is the patient's situation? Like, are they sedated? Are they paralyzed? Are they awake and breathing? That kind of stuff. Because reverse trigger, you have to have a certain like, uh, there's a pattern, right? Meaning you have to have this pattern, but the patient should be sedated heavily. It sort of comes up when you think the RAS is -5 and, you're like, but for some reason they're double triggering type deal. And then you look at the pattern, you're like, wow, this is a double trigger. It's a reverse trigger. That was
Yeah,
long.
I think you broke it out down pretty good. So from what I remember about this scenario, the patient was a difficult to synchronize patient with a neuro-based a head injury.
Ah,
And
okay.
the spontaneous breaths you see there were kind of what the patient's baseline efforts were looking like. And they were trying to make the patient more comfortable and were getting more and more and more sedation. And then they were having this differing morphology that some spontaneous breaths, but then some pauses in their neurodrive to breathe, that then a machine breath would be triggered and then would
Interesting.
invoke this reverse trigger phenomenon. So, but everything else you mentioned was spot on. The one thing about the Hamilton T1 is it auto adjusts the y-axis. So given enough time and enough spontaneous breaths, you would have seen that whole flow
Oh,
on
okay,
the
got it.
spontaneous breaths and seen that they were a very short, almost like a hiccup breath that
Right.
this neuro patient was having.
Yeah,
So it's just a very difficult to synchronize patient. And they kind
exactly.
of came to me saying like, what the heck's going on? But it brought up a couple really good avenues to chit chat about like the amount of support we give patients and sometimes the implications of lowering that support. And then also a great conversation regarding specifically reverse triggers and recognizing it and then things to watch for with sedation levels. So they were able to actually decrease sedation and remove the reverse trigger and then
Mm,
work through trying to synchronize as best they could with the neuro drive that they had.
interesting. So it was sort of the right milieu, meaning the patient like had a lot of there was a lot of sedation on board.
Yes.
Got
Yeah.
it. Okay, interesting. All right. So that exactly. So reverse trigger is sort of, I mean, if you guys took care of patients during the pandemic, like this was, I mean, just rampant,
Yeah.
much more throughout. Like just I there was a lot of times where we recognized reverse trigger because of how much sedation the patient was on, and the RASS is -5, like you can't wake them up at all. They're maxed out and everything, but they're still double triggering. I actually have a great picture that I can like sort of pop in. Um, that a nurse was like very upset one night because the patient was prone and they had ARDS, they had COVID, it was the whole deal. And she's like, the patient's still double triggering. Like we need to do something about it. And I was like, that's a reverse trigger. And they are
Mhm.
very adamant that they're double triggering and I needed to do something about it. And I'm like, I can't, like it's a double trigger, like went through the whole thing. So unfortunately, like with this situation, it's a little bit different because if you can lighten the sedation, as you mentioned, that is one way to get rid of it. There is a it's based on this sort of like neurologic um I don't want to call it like a theory because it's like been proven. It's like called entrainment, which is the body is reacting to its outside environment patterns. So if the brain is entrained that one is that you can have 3-to-1 trigger, 3-to-1 reverse triggering, 2-to-1, 1-to-1, meaning every breath is a reverse trigger. You could have it patterned like 2-to-1, so every other one's a reverse trigger. You can have 3-to-1, every other, every two, that third one is a reverse trigger. So it's actually more like in depth, and there's some papers on it. I could probably link into this as well because it's very interesting actually. But what it has to do with is once a patient's super sedated, and or comatose, because this happens in patients who are brain dead as well. When the diaphragm is loaded with pressure and flow, when the vent fires, it takes advantage of that reflex, which is to contract. So the diaphragm contracts. So if the patient's just over sedated, let's say in air quotes over sedated, you can lighten the sedation if that's safe. Number two is you could drop the rate and just allow the patient to trigger and just sort of get out of the patient's way because some people some people classify this as early trigger. That's how the Cleveland Clinic folks classify it, not so much reverse trigger. They call it early trigger because the machine trigger is coming early than when the patient wants it. So the thought is if you drop the respiratory rate from like this one's 24, if you just dropped it to like 12 and let the patient breathe at 15, then every breath would just be a spontaneous breath. Like you wouldn't have any reverse triggers in there, right? Then the third thing is in my situation with my friend who had COVID and was prone and it was a whole shebang, I just had to paralyze him, unfortunately, right? And that's like we hate to do that because obviously that's definitely not diaphragmatic protective, but we kind of have to do what we have to do sometimes. But unfortunately, I think a lot of people were paralyzed in the face of reverse trigger when providers thought it was like a double trigger situation. Whereas if you did some stuff with the ventilator, you might be able to like sort of rectify the situation. You know what I mean? So was that true? Was there autopy present?
I can't remember
I
all
mean,
the
no, okay,
specifics,
yeah,
but yeah,
got it.
like, but
Yeah,
the patient was definitely,
right,
like I think a little bit of that was happening because of the rate that was set and just like
sure,
not necessarily matching what they were
yeah,
naturally doing.
exactly,
One really kind of good way, if the reverse trigger is sedation based, one good way to kind of navigate through whether that's what you're dealing with is just to throw your patient into pressure support. Because if it is
yep,
truly that they're snowed, like I like to use the analogy with reverse triggers is for sedation based reverse triggers, it's this kind of poke and breathe analogy that like if you had someone who has heavy sedation, you're trying to get them to breathe on their own, when you can kind of like shake the patient, hey, Bobby, take a big breath in, just chose the name Bobby randomly. Like, and then they'll breathe, right? Because you're stimulating them. And like in the
right,
case of sedation induced reverse triggers, essentially that breath is that reminder to be like, hey, like wake up and breathe. And they're like, oh crap, I gotta breathe. And then they breathe while a breath is being given. And you have this like stacking almost like it kind of can look like a stack or a double trigger. But like if you put them into pressure support, they're snowed enough that sometimes they just won't even trigger and then they'll be apneic. And it's this
right,
like really bad in between. So that's kind of how I like to explain it. Sometimes when I'm at the bedside and I'm asking the nurses to potentially drop sedation and they're a little bit confused, and I'll literally throw them into pressure support and see like, look, your patient is snowed, so snowed that they're not
right,
even breathing.
right,
Like, no, they're deep enough. And this is why we're having the problem. And then
right,
sometimes that's enough for them to be like, oh, I get it. Okay. Like
right,
we want them to at least have that triggering and that breathing.
right,
And then once we get there, then absolutely what you mentioned about dropping the rate
right,
in a control mode is a great option.
right. Sometimes, yeah, and sometimes what I'll do is like I'll bring everyone to the bedside and say, and because usually the argument is that it's a double trigger, and I'll say a double trigger is the first breath is patient triggered, right?
Mhm.
But reverse trigger, by definition, the first breath is machine triggered. So I show them like, there's two breaths here. The little white line goes on the servos when the patient triggers the vent. It's a little white line. The little white line is in the second breath. It's not in the first breath. So the first breath is machine triggered. The second breath is patient triggered. So that's not double trigger, that's reverse trigger. So like showing that there's a very specific pattern to it. Like the first breath is machine triggered, the second breath is patient triggered. Sometimes like elucidates that like how it could look so how it could look so much like a double trigger but not be a double trigger because it's completely different. And
Mhm.
then one of the there's when I was a fellow, one of my co-fellows was arguing with I forget who it was. It might have been the SICU. I think it was the SICU attending. The SICU attending was like, this patient's double trigger and we need to like paralyze them the whole shebang. And she was like, no, it's a double trigger. And like, we were all going through the vent course, and so we were all we wanted to assert our dominance. So she wound up popping him on pressure support, like exactly what you did, and then the patient wasn't breathing at all, because he was like RAS -5, completely snowed to the gills, and the SICU attending was like very adamant that the patient was double triggering, and my co-fellow was like, "This is not double trigger, it's reverse trigger. We need to bring the sedation down. We need to do this, do that," and he didn't believe her, so she put him on pressure support, and the patient didn't breathe for like 30 seconds or something, and so he I don't remember if he actually wound up believing her or not, probably just like stuck to his guns, but that's one way you can prove that it's a reverse trigger is pop the patient onto pressure support. Then normally what'll happen is they'll just start breathing at some number, right? If they're not like paralyzed, they'll just breathe at like 13 or something. And if you just like dial in that rate that the patient wants, then you just get the ventilator out of their way.
Yeah.
If you can't safely like lift their sedation for some reason. Although there's very few reasons why you need to be -5, right? Like unless you're paralyzed or something, or whatever the case may be. Like usually you can like lighten the sedation and then get out of it that way. But if like the machine rate is kind of close to the intrinsic rate, the machine could kind of get in the way of the patient's intrinsic rate. So if you just drop the machine rate, then you just let the patient do what they want. You know what I mean? But
Mhm.
like reverse trigger has the inference that like you're exposing this Herning Brunner reflex. Again, I can't say it or spell it, just look it up. So, but that has what it has to do with.
It's a
Interesting. Very
fun,
good.
it's a fun asynchrony or dysynchrony to deal with. Like it can be frustrating, but it is once you see it and once you recognize it, it's something that you won't ever
Yeah.
not see.
I think it's
It
much more, it's more pervasive certainly than you would think.
Yes.
It's certainly more pervasive than you would think. Awesome.
Well done, Nick. That was great.
Thank you, Melanie. Oh my God. All right. I probably have